Occupational English Test. Listening Test. This test has 3 parts. In each part, you'll hear a number of different extracts. At the start of each extract, you'll hear this sound. You'll have time to read the questions before you hear each extract, and you'll hear each extract once only. Complete your answers as you listen. At the end of the test, you'll have 2 minutes to check your answers. Part A. In this part of the test, you'll hear 2 different extracts. In each extract, a health professional is talking to a patient. For questions 1 to 24, complete the notes with information that you hear. Now, look at the notes for Extract 1. Extract 1, questions 1 to 12. For questions 1 to 12, complete the notes with a word or short phrase that you hear. You now have 30 seconds to look at the notes.
Doctor, I've been dealing with this persistent cough for a while now, and it's getting worse. It usually flares up later in the day, especially after I eat. I've also noticed it seems to trigger my heart palpitations, which have been more frequent recently.
I see. When did you first notice the cough, and when did the palpitations start becoming more frequent?
The cough has been a problem on and off for a few years, but it's become much more bothersome in the past few months. The palpitations have been occurring since around 2008, but they've really picked up in the last few months as well.
Have you noticed any specific foods or activities that make your cough or palpitations worse? And you mentioned that these symptoms tend to worsen after eating. Could you tell me more about your diet?
I can't pinpoint any specific foods that make it worse, though I've tried cutting down on acidic foods and caffeine. I switched from coffee to tea, thinking maybe caffeine was the issue, but it hasn't made much difference. It's frustrating because the palpitations sometimes feel more intense right after the coughing spells.
That must be quite uncomfortable for you. Have you used any medications for these symptoms recently or in the past?
I was on a medication for acid reflux a while back, but it actually made my cough worse, so I stopped taking it. I haven't taken anything for the reflux or the cough since then. I'm really trying to avoid medications if possible. I just want to understand what's causing this.
Understood. It's good that you're monitoring your symptoms closely. Regarding the investigations you've had, you mentioned a series of tests were conducted. Could you elaborate on those?
Sure, I've had a full run of tests, a stress test, thyroid levels, cholesterol, and pulmonary functions, all normal. They even checked my sinuses to rule out issues there. Most recently, my doctor suggested a Holter monitor to check on these palpitations more closely, and there's talk of maybe doing an echocardiogram.
That's comprehensive. It helps to rule out many potential issues. Have you had any recent changes in your lifestyle or stress levels that might be contributing to these symptoms?
Not particularly. I've been trying to stay active and manage stress through regular walks and downtime, but it's stressful not knowing what's causing these symptoms, which might be making them worse.
I understand that can be very distressing. Based on everything you've shared, it's clear your symptoms are impacting your daily life significantly. Let's look at the data we have and discuss the next steps. Your vital signs are stable, which is good. Your blood pressure is a bit on the higher side, but nothing alarming. Your heart rate and other vitals are within normal limits. Your laboratory tests, including complete blood count, kidney and liver function, and thyroid levels, are all normal. This is reassuring and helps us focus on other potential causes of your symptoms. The imaging tests, including the chest and sinus X-rays, didn't show any acute disease, which is good. The EKG confirmed a normal rhythm without signs of ischemia or arrhythmia during your visit. These results help us rule out many cardiac and pulmonary conditions. Considering your history and the recent increase in symptoms, the next logical steps are to proceed with the 24-hour Holter monitor to assess any arrhythmic events that correlate with your symptoms. The echocardiogram will provide us with a detailed view of your heart's structure and function, which is crucial given your palpitations. Additionally, I recommend an upper gastrointestinal examination. Given your history of acid reflux and its temporal relation to your cough, assessing for conditions like gastroesophageal reflux disease, GERD, or hiatal hernia could be informative. In the meantime, continue to monitor your symptoms and keep a detailed diary of your cough and palpitations, noting when they occur, their severity, and any potential triggers. This information will be invaluable for our next consultation. We'll review all these findings at your follow-up visit. Based on those results, we can adjust our approach, potentially exploring further diagnostic tests or treatments. It's important to address both the symptoms and the underlying causes to improve your quality of life.
Thank you, doctor. It helps to have a plan and to know that we're looking into all possible causes. I'll start the symptom diary today and continue monitoring how things evolve.
That sounds great. We'll reconvene after the initial tests and decide on the next steps. It's important to me that we find the cause of your symptoms and address it appropriately. If you have any concerns in the meantime, please don't hesitate to contact my office.
Extract 2, questions 13 to 24. For questions 13 to 24, complete the notes with a word or short phrase that you hear. You now have 30 seconds to look at the notes.
Doctor, I've been struggling a lot with my knees lately. The pain is almost constant, and while ibuprofen usually helps a bit, it just doesn't seem enough anymore. It's tough, especially during my night shifts. I've been trying to manage with just over-the-counter pain meds for years now, but it's getting worse. I had my knees x-rayed a while back, and they told me it was osteoarthritis. The joint narrowing and surface degradation are pretty clear, they said. Honestly, I'm worried about how I'll manage when I retire. I want to be active, go fishing, and enjoy my time, but this pain is a real barrier.
I see, and it sounds like you've been quite proactive in managing your symptoms so far. How have you found the ibuprofen in terms of managing your pain on a scale of 1 to 10?
Before I take ibuprofen, my pain is usually around an 8, but the pills bring it down to about a 6. It helps, but as I said, it's not enough. The pain never really goes away, it just becomes slightly more bearable. I try to stay active, because I've read that it helps, but it's a challenge.
That's understandable, and staying active is generally beneficial, but it's also important to not overdo it. How about your other medications? I noticed there are some changes and some confusion, particularly with your metoprolol. How's that going?
Right, about that. I was supposed to take it twice daily, but I've only been taking it once. It's a bit hard to keep up, especially with my night shifts. It throws my whole schedule off.
Okay, that's good to know. It's crucial we adjust that to ensure your blood pressure is well managed. You mentioned retiring soon. How do you feel about that, especially with your health concerns?
I'm looking forward to it, honestly. I love fishing and just being outdoors. But with my knees and my overall health, I'm not sure how much I'll actually get to enjoy it. There's also my diabetes and heart condition to think about. My last A1C was 6.6, which I guess is good, but it's a lot to manage.
It sounds like you have a lot on your plate. Let's take a look at your recent labs and see what we can optimize. Your blood pressure has shown a gradual increase, currently at 143/70 mmHg. Your weight has also increased. Currently, you are at 250 pounds, which classifies you as obese. Both of these factors contribute significantly to the stress on your joints and your overall health.
Yes, I've been trying to watch my diet, more vegetables and less salt, but sometimes I indulge in fried foods and red meat. It's hard to always stick to the diet.
It's okay to indulge occasionally, but moderation is key, especially with your history. Looking at your cholesterol levels, your total cholesterol is at 190 milligrams per deciliter, with an LDL of 110 milligrams per deciliter and HDL at 40 milligrams. Your liver and kidney functions are stable for now, but your creatinine is at 1.4 milligrams per deciliter and EGFR at 59, which indicates mild renal impairment. Your inflammatory markers like CRP are elevated at 8 milligrams per milliliter, which isn't surprising given your osteoarthritis.
Does that mean my arthritis is getting worse?
It could indicate more active inflammation. Also, your vitamin D is slightly low at 20 nanograms per milliliter, which is important for bone health. Your TSH and free T4 levels are normal, so your thyroid is functioning well. Your bone density scan shows osteopenia at the hip joint, which means your bones are weaker than normal, but not to the extent of osteoporosis yet.
So, what do we do from here? I really need some relief.
Given your ongoing pain and the results of your investigations, I would suggest optimizing your pain management by potentially starting you on tramadol. This should help manage your pain better than ibuprofen alone. We will renew your current medications, including properly adjusting your metoprolol to twice daily as prescribed. It's also vital to continue monitoring your chronic conditions closely. Let's plan a follow-up in 6 months to reevaluate your treatment regimen and see how you're doing. In the meantime, we can look into some physical therapy options to help manage your arthritis better and discuss any other supportive measures you might need.
Thank you, doctor. I appreciate your help. Hopefully, this new plan can make a difference.
That is the end of Part A. Now look at Part B. Part B. In this part of the test, you'll hear 6 different extracts. In each extract, you'll hear people talking in a different healthcare setting. For questions 25 to 30, choose the answer A, B, or C, which fits best according to what you hear. You'll have time to read each question before you listen. Complete your answers as you listen. Now look at question 25.
Good morning, everyone. Today, we delve into the challenges faced by elderly individuals with mental illness, a pressing issue as our population ages. This demographic is prone to a spectrum of mental health issues, which often coexist with physical health problems.
That's correct. A significant challenge is the dual stigma associated with aging and mental illness. This stigma can lead to social isolation, which exacerbates symptoms and severely impacts the quality of life. Elderly patients often suffer in silence, reluctant to seek help due to societal prejudices.
Indeed, and diagnosing mental illness in the elderly is particularly complex due to the overlap of symptoms with other age-related conditions such as dementia. It's crucial for healthcare professionals to differentiate between these to provide accurate diagnoses and appropriate care.
Moreover, we must consider the pharmacological management challenges. Elderly patients typically have altered drug metabolism, which requires dose adjustments and vigilant monitoring to avoid adverse effects. The potential for drug interactions is high, given that many may be on multiple medications for various chronic conditions.
Absolutely. All these factors underscore the need for an integrated approach in healthcare that combines mental and physical health services. Healthcare providers should be trained to recognize and address the unique needs of this population to improve their overall well-being.
Now look at question 26.
Team, we need to address the significant adverse reaction we're seeing. The patient is currently exhibiting tachycardia and hypotension postoperatively, which are concerning symptoms that require immediate intervention.
I've reviewed the vitals, and the patient's blood pressure is critically low. We need to act fast. I recommend we start with an intravenous fluid bolus and prepare for vasopressor support if there's no rapid improvement. Monitoring and responsiveness are key here.
Agreed. Additionally, let's double-check all anesthetics and surgical medications for any potential allergens or dosage errors. We need to ensure there's no underlying cause that we're missing. Safety checks are absolutely crucial in these situations.
I will get the medication chart and review it immediately. Let's also keep the communication lines open with the patient's family to keep them updated on the situation. Ensuring the patient's stability is our immediate priority, and we need all hands on deck for this.
Now look at question 27.
Today's focus on asthma trigger avoidance is crucial, especially as we see an increase in patients experiencing severe episodes. Educating our patients about avoiding smoke, dust, and extreme weather conditions is essential, but we also need to consider other less obvious triggers.
Absolutely. Emotional stress is a significant trigger for many. We should be advising our patients on stress management techniques like mindfulness, meditation, and relaxation exercises. Integrating mental health support into our asthma care plans can make a real difference.
And let's not overlook dietary triggers. Certain foods and food additives can exacerbate asthma symptoms. It would be beneficial for our patients to consult with a dietitian. We could also provide lists of foods to avoid and safe alternatives, which would be a practical tool for our patients.
That's a great idea. Let's compile a comprehensive guide on trigger avoidance that includes all these aspects. We can distribute this during patient education sessions and perhaps even host some workshops. This proactive approach could significantly reduce emergency visits and improve our patients' quality of life.
Now look at question 28.
Today, we address the critical issue of patient exploitation within hospitals, encompassing financial exploitation, privacy violations, and neglect. These are serious concerns that compromise patient safety and trust in healthcare institutions.
Indeed, the rise in data collection poses an increased risk of privacy breaches. Hospitals must enforce strict protocols to protect patient information and ensure that all data handling is compliant with privacy laws. Transparency with patients about how their data is used is also crucial.
From a staffing perspective, ensuring that all medical and support staff are thoroughly trained and vetted is essential in preventing neglect and abuse. Regular training and audits can help maintain high standards of care and ethical conduct.
Additionally, patient advocacy groups are vital in this equation. They provide oversight and a voice for patients who might feel powerless or intimidated. Creating strong channels for complaints and feedback that are genuinely taken into account can prevent many cases of exploitation.
Now look at question 29.
I understand that receiving a diagnosis of chronic hepatitis B can be very overwhelming, but it's important to know that with the right treatment and lifestyle changes, it is manageable. Your quality of life can still be very good.
That's reassuring, but I'm worried about what kind of changes I'll need to make. And what about my family? How does this affect them?
For starters, you'll need to avoid alcohol as it can further damage your liver. We'll also discuss antiviral therapies that can help control the virus. As for your family, it's crucial that they get tested and vaccinated to prevent transmission. This disease can spread through blood and bodily fluids, so precautions are necessary.
I appreciate the clarity. How often should I come in for checkups, and what kind of monitoring will be involved?
We'll start with liver function tests every 3 months to monitor how your liver is responding to the treatment. Depending on your response, we may adjust the frequency of visits. It's also important to maintain a healthy diet and regular exercise, which we can discuss in more detail during your visits.
Now look at question 30.
Vaccinating close contacts is a critical strategy, not only for protecting individuals directly, but also for reducing the overall spread of the virus within communities. This approach is particularly effective in containing outbreaks and minimizing transmission.
I completely agree, and achieving herd immunity is crucial. However, we must also consider the challenges such as vaccine availability and public hesitancy. These factors can significantly hinder our efforts to vaccinate effectively.
Indeed, but through comprehensive public education and transparent communication about the benefits and potential risks associated with vaccination, we can enhance public trust and improve vaccine uptake. It's about building a community-wide understanding of how vaccines work and their benefits, not just at an individual level, but for public health at large.
Furthermore, prioritizing vaccine distribution to high-risk groups and close contacts can make the most of our limited vaccine supplies. This targeted approach not only protects the most vulnerable, but also maximizes the impact of our vaccination efforts. ensuring we curb the pandemic more effectively and efficiently.
That is the end of Part B. Now look at Part C. Part C. In this part of the test, you'll hear two different extracts. In each extract, you'll hear health professionals talking about aspects of their work. For questions 31 to 42, choose the answer A, B, or C, which fits best according to what you hear. Complete your answers as you listen. Now look at Extract 1.
Welcome everyone to today's seminar on the latest advancements in the management of heart failure. I'm Dr. Leslie Chang, and it's my pleasure to delve deep into the complex world of heart failure treatment, especially focusing on the integration of the newest ACC and AHA guidelines into our clinical practice. Heart failure remains a leading cause of morbidity and mortality worldwide, necessitating an ongoing evolution in our approach to its management. The recent guidelines published by the American College of Cardiology and the American Heart Association in the journal Circulation mark a significant step forward in aligning treatment protocols with the latest evidence-based research. Let's start by discussing the case of a 65-year-old male patient, Mr. Smith, who presented with worsening dyspnea and fatigue. He has a history of diabetes mellitus type 2 and was previously diagnosed with heart failure with reduced ejection fraction, HFrEF. His initial ejection fraction was 35%, and he was on a regimen including an ACE inhibitor and a beta blocker. Despite adherence to this regimen, his symptoms have progressively worsened over the past few months. This case highlights the necessity of re-evaluating our treatment approach in light of new guidelines. One of the major updates in the 2021 guidelines is the stronger emphasis on the use of ARNI, angiotensin receptor neprilysin inhibitors, and SGLT2 inhibitors as part of the guideline-directed medical therapy, GDMT. Research has shown that ARNI, compared to ACE inhibitors, significantly reduces the risk of cardiovascular death and hospitalization for heart failure patients. This was demonstrated in the landmark PARADIGM-HF trial, which shifted the treatment paradigm by showing a 20% risk reduction in death from cardiovascular causes with ARNI compared to enalapril. In Mr. Smith's case, transitioning him from an ACE inhibitor to an ARNI could potentially improve his clinical outcomes. Furthermore, considering his diabetes, introducing an SGLT2 inhibitor might not only help manage his heart failure, but could also have beneficial effects on his glycemic control. The DAPA-HF and EMPEROR-Reduce trials have robustly demonstrated that SGLT2 inhibitors reduce heart failure hospitalizations and cardiovascular death in patients with HFrEF regardless of the presence or absence of diabetes. Another pivotal update from the new guidelines is the classification and treatment adjustments based on ejection fraction. Previously, the focus was predominantly on HF/EF, but now there is more detailed guidance on managing heart failure with mid-range ejection fraction, HF/MREF, and heart failure with preserved ejection fraction, HFpEF. For patients like Mr. Smith, whose initial ejection fraction is in the lower range but could potentially improve with optimized treatment, it's crucial to monitor changes in ejection fraction over time. If his ejection fraction improves and enters the mid-range category, the treatment strategy may shift slightly, emphasizing continued use of GDMT, but adjusting the dosages and combinations of medications according to his current clinical status. Importantly, the guidelines also stress the role of individualized care. Each patient's comorbid conditions, socioeconomic status, and personal preferences should be considered when devising a treatment plan. For instance, cost and access to medication can be significant barriers. Thus, integrating discussions about generic options or pharmaceutical assistance programs can be crucial components of care. The integration of the new heart failure management guidelines into clinical practice provides us with a more structured and evidence-based approach to treating this complex disease. For Mr. Smith, applying these guidelines not only offers a chance for symptomatic relief, but also improves his overall prognosis by targeting the underlying pathophysiological mechanisms of heart failure with the most effective, modern therapeutic options available. As we continue to navigate these guidelines, let's prioritize continuous education and adaptation of our practices to ensure that all heart failure patients receive the most comprehensive and effective care possible. Thank you for your attention, and I look forward to our discussion and any questions you might have about these exciting developments in heart failure management.
Now look at Extract 2. Extract 2, questions 37 to 42. You now have 90 seconds to read questions 37 to 42.
Welcome to today's episode of Healthcare Insights. I'm joined by Dr. Lisa Kimball, a distinguished professor of medicine and an expert in infectious diseases. Today, we delve into the complex world of antimicrobial resistance in sexually transmitted infections, or STIs, with a focus on the recent shifts in treatment protocols as recommended by the CDC's 2021 guidelines. Dr. Kimball, thank you for joining us.
Thank you for having me. It's a critical time to discuss these issues, especially with the ongoing changes in STI epidemiology and treatment approaches.
Absolutely. Let's start with a case study that I think will set the stage for our discussion. We recently treated a 29-year-old male patient, John, who presented with symptoms of urethritis. His case was complicated by the fact that initial treatments with standard antibiotics were unsuccessful. Further testing confirmed the presence of antibiotic-resistant Neisseria gonorrhea. Could you elaborate on how antibiotic resistance has become a major concern in STI treatment?
Certainly. John's case isn't unique, unfortunately. Over the years, Neisseria gonorrhea, the bacterium responsible for gonorrhea, has developed resistance to multiple antibiotics. This includes penicillin, tetracycline, and fluoroquinolones. Recently, we're seeing worrying trends with resistance to the current first-line treatment, ceftriaxone. This situation forces us to rethink our approach and underscores the need for new treatment strategies.
That leads us to the new CDC guidelines. Could you discuss the major updates and how they aim to address these challenges?
The 2021 CDC guidelines have made significant revisions, particularly for the treatment of gonorrhea. The previous recommendation was dual therapy with ceftriaxone and azithromycin. However, due to rising concerns about antimicrobial resistance and in light of stewardship principles, the new guideline recommends a single increased dose of ceftriaxone. This change aims to simplify treatment, reduce the use of azithromycin, and hopefully slow the development of resistance.
What about other STIs like chlamydia and syphilis? Are there updates concerning these infections as well?
Yes, there are updates across the board. For chlamydia, the guidelines now prefer doxycycline over azithromycin, especially for rectal infections, where doxycycline shows better efficacy. As for syphilis, the treatment remains primarily with penicillin, which thankfully syphilis has not developed resistance to. However, the guidelines emphasize more frequent screenings and treatment in pregnant women to prevent congenital syphilis, which has seen a dramatic increase.
With these updates, how do the guidelines address the management of STIs in special populations?
That's an excellent point. The guidelines have expanded their sections on special populations, including individuals with HIV and those who are pregnant. There's a strong emphasis on tailored approaches that consider the specific needs and health dynamics of these groups. For example, the guidelines recommend regular screenings for syphilis among men who have sex with men and frequent HIV testing.
In light of all these changes, what are the challenges healthcare providers face in implementing these guidelines?
The challenges are manifold. Firstly, there's the issue of education and ensuring that all healthcare providers are up to date with the new guidelines. There's also the challenge of access to care. Many patients with STIs may not have easy access to healthcare services, which complicates efforts to treat and control these infections. Lastly, the ongoing issue of stigma associated with STIs can deter individuals from seeking the care they need.
Absolutely, the social dimensions of healthcare are as crucial as the medical ones. Dr. Kimball, as we wrap up, could you share your thoughts on future directions in the field of infectious disease, particularly in the context of STIs?
Looking forward, it's crucial that we invest in research for new antimicrobials and alternative treatments. Public health efforts must focus on prevention through education, vaccination where applicable, and broader access to health care. Additionally, we need to enhance our surveillance systems to track the spread of resistant strains more effectively. Only through a comprehensive and inclusive approach can we hope to stay ahead of these infections.
Dr. Kimball, thank you for sharing your expertise and insights today. It's clear that tackling STIs in the era of antibiotic resistance requires a multifaceted approach. Thank you to our listeners for joining us on Healthcare Insights. Stay informed and stay healthy.